welcome to our newest podcast for the Trauma Anesthesia Society. I'm Josh Sappenfield. I'm here with Kevin Blaine, and we'll be your hosts. This is kind of a hot topic. We're going to talk about COVID-19. It's the latest coronavirus that's made its spread around the globe. I had the chance to interview Dr. Bob Webster from Vanderbilt talking about ventilators. And Kevin got to interview a few people.
Yeah, that's right. So I got a chance to speak with Mike Aziz at Oregon and Philip Kurian at UCSF to talk about airways and PPE.
And I guess this is like the topic on everyone's mind, from everything happening in New York City to length of stay to people being quarantined for 2 weeks after a travel and such. I know that most people's operating room censuses are down, which I think is a huge financial issue for the hospitals, not even starting with the communities and restaurants and stuff shutting down. And so I guess there's a lot of concern about it.
Yeah, I think we're all struggling. I know we are at my shop to try to figure out how we can get around this. How can we keep the doors open? How can we fulfill our community needs? It's disrupted just about every aspect of what we do.
And it sounds like there's been a lot of creative solutions on how to make the budget work, from people giving up PTO to just having to take part-time shifts.
Which I think leads us into our topics for today, because there's plenty of material out there now about COVID-19 in various aspects, testing, policy responses. But we got interested in some of the more nitty-gritty on-the-ground issues that we're facing, and in particularly trying to come up with maybe unique, creative solutions to some of the problems that we're facing. Hopefully, we'll never come to needing some of these approaches, but as we'll hear from Dr. McIsaac, it's really important to be thinking down the road and having contingency plans for what happens when our resources are fully sapped. Because we don't ever want to be in a situation of watching a patient die in front of us of what would in normal times be a treatable or preventable condition. Our first speaker today is Dr. Jay McIsaac, who is perhaps the leading advocate for the role of anesthesia providers during emergency events. He's organized several training sessions for mass casualty events at the annual American Society of Anesthesiologists meeting. In his professional life, Dr. McIsaac practices as a partner and director of Integrated Anesthesia Associates of Hartford, Connecticut. He is the chief of trauma anesthesia at Hartford Hospital. He's also a clinical professor of anesthesia at the University of Connecticut School of Medicine. He's a Trauma Anesthesiology Society board member and a member of the ASA Committee on Trauma and Emergency Preparedness. Welcome, Jay.
Thank you for inviting me.
So the current COVID situation has proven to be a challenge for acute care anesthesiologists around the world. This series of interviews will address a few key issues, but we wanted to start by getting your perspective on these events. Can you briefly bring us up to date on the COVID crisis, where it started and where we are now?
Well, I think this crisis should not really be a surprise for anyone. We've been aware of the need to prepare for pandemics and mass casualty disasters since the early 90s. And we certainly also have known there's a long history of emerging disease that originates in China and spreads around the globe, influenza being the classic example. The anthrax attacks followed by the SARS, the MERS, and the H1N1 flu gave us plenty of warning during the past 20 years. And now COVID-19 was actually something predicted in a paper from 2007, almost verbatim. Unfortunately, except for a small group of individuals in the disaster preparedness community, COTEP being one of those groups, no one was really interested. So now we find ourselves rushing into battle poorly armed against the very aggressive enemy, and we all find it very frustrating.
It certainly does feel a bit like we're a little bit behind the curve. You know, it feels like we're reacting, not proacting. What do you think the role for anesthesiologists is in the response to COVID?
Well, I think first of all, it's leadership. I think we have the responsibility to tell our colleagues, both in our specialty and in others, our administrators and our political leaders, the truth about what we know, what we don't know, and what we need to fight this, whether that's PPE and ventilators, whether it's better training, better funding, probably all of those. Secondly, our traditional role in maintaining quality and patient safety in the operating room, despite this challenge, is critical. We can't let ourselves slide backwards on that. And then thirdly, I think we need to rise to the occasion and really expand our scope of practice, both to critical care and also the emergency medicine sphere. This is actually something done routinely in many other countries around the world, especially in Europe. But in many places, the anesthesiologist actually cares for patients across the whole spectrum, from the pre-hospital all the way through emergency department, operating room, critical care, and sometimes even post-critical care on the wards.
Do you see many cases of anesthesiologists, OR anesthesiologists, being drafted into providing critical care services at their hospitals?
Oh, absolutely. I think anesthesiologists are very well positioned for critical care. As you know, critical care really originated with our specialty, and we've all done critical care specifically as part of our training, but what we do every day is essentially critical care on the smaller scale in the operating room. So we're very well positioned, well trained, and have the vast majority of skills, even if we don't commonly work in a critical care setting ourselves. It's a very easy transition.
And I'd agree with you. Of course, I'm an intensivist myself, so I have a little bit of a bias there. We clearly bring a lot of strengths that could be brought to bear in the management of this virus, but I wonder, what do you think are the biggest challenges facing anesthesiologists?
Well, certainly airway management in the face of a highly infectious agent that spreads from respiratory secretions is number one on my list. Not only do you need to protect yourself, but the rest of the staff working around you. And you need to be safe for the patient at the same time. I think finding creative ways of reducing spray and aerosols goes a long way, whether it's a simple sheet of plastic that you pass the circuit through, to an evacuation system that you can jury-rig from a couple of circuits in the wall suction. But I think anything we do to contain the spread really raises the safety for everyone involved. So that's number one. Certainly, having proper protective equipment is a big problem. We need to keep ourselves and our colleagues healthy, obviously. So not only do we have to wear the right garb and protect ourselves, but the nurses, the respiratory therapists, all the other folks working around us do as well. Many hospitals really fail to stockpile enough PPE. Some don't have any at all. The states and the federal governments are just as equally at fault. And it's not just current government. It's going back 30 years. There's been a failing on the large scale. There's huge pressure to use minimum levels of protection and to reuse potentially infectious masks and equipment. You know, an N95 is by definition contaminated after it's used. The assumption is you're using it because the air is contaminated and you have a concern. And it only offers a fairly low protection factor of 10. It's not optimal by any means. The PAPR, the Powered Air Purifying Respirator, has a protection factor of around 1,000, but there's not many available in most institutions. Some have none. They require a fair amount of maintenance over time to make sure they work and are available. And they require some training as well as a medical exam before you use them. COVID-19 patients should really be in negative pressure rooms as well. But most hospitals only have a few at most, if they have any at all. And most hospitals have positive pressure operating rooms that may not be switchable. Certainly, lack of ventilators is another huge problem that was anticipated for years, but fairly ignored. The national stockpile only had 12,700, and that's not even enough probably to handle New York City, let alone the rest of the country. attempts to jerry-rig devices with hardware store materials or devices that automatically squeeze an AMBU bag are probably not going to be efficacious for patients with ARDS. I am hoping somebody comes up with something that does work well. But if you're too simplistic, you're not likely to really be able to take care of these difficult to ventilate patients. And then certainly if you're going to build your own ventilator, you need to have safety mechanisms, pressure volume measurements, and things that make it a safe and modern device, which the typical AMBU bag doesn't really fit. I really look forward to results from the auto and the other industrial manufacturers who are repurposing their production lines based on the new defense appropriations orders. Hopefully we'll get some high-quality, easy-to-use devices that are relatively affordable, if not paid for by somebody else, although ultimately it's still the taxpayer that will pay for it. And finally, I think stress management is a huge challenge for all of us in our specialty. Not only are almost all of us taking a huge financial hit, especially the private practice stocks, but we're also worried about our loved ones, ourselves, and all of those that work with us. And, there's also that stress of seeing so many suffering patients that is with us constantly while we're at work and when we're at home.
Yeah, it is tough when we're seeing the patients and even people around us that are worried about contracting a virus that they haven't yet gotten. God willing, they never will, but they may. I think most of us are anticipating that the COVID virus, the epidemic is going to get worse before it gets better. Where do you think this epidemic is going?
Well, I think that's not an unreasonable assumption. I think we'll win. We have flattened the curve a little bit, but unfortunately, there's plenty of people that are out there ignoring the social distancing rules and all the other things that we're trying to put in place to reduce the contagion and reduce the peak. But I think it'll be a long and slow fight. It'll be costly in many ways, not just financially and in the matter of lives, but just in the stress that we all have to go through. But I think we'll eventually conquer it in the end, and hopefully treatments and effective vaccines are not too far away.
Do you think that the practice of anesthesiology is going to change after this, when we come out on the other side?
I hope it does. I hope we'll make disaster preparedness as much a part of our training as many of the routine things we always did. We train at least yearly on malignant hyperthermia, but most of us will never see it in our entire practice. On the other hand, mass casualty events, whether it's a large-scale trauma, a war, a contagion, an industrial accident, is much more likely to happen on a statistical basis throughout our own country and around the world, but also to us eventually, as we're seeing now. I hope this is really a call to our specialty to broaden our scope of practice outside the operating room, to broaden the training for residents, but also for ongoing staff.
Excellent. Well, thank you very much, Dr. Isaac. You've been a tireless advocate for training for emergency preparedness within the anesthesia profession. So clearly, we've proven you're right. Your advocacy has borne out. So we thank you for your expertise, and thank you very much for speaking with us here today.
Thanks very much for having me.
I'm talking now with Dr. Michael Aziz at Oregon Health and Science University. He is an airway expert and was the co-author of the Anesthesia Patient Safety Foundation's February article on airway management during COVID, as well as the vice chair of anesthesiology and perioperative medicine at OHSU. We're here today to talk about issues regarding airway management with this disease. Welcome, Mike.
Hi, Kevin. Thanks for having me.
Oh, thank you. A lot of anesthesia providers are concerned about their occupational exposure to the virus during airway instrumentation. Can you describe for us the specific risks that come from intubation?
Sure, Kevin. We don't really know is the answer. There's got to be risk there because we know that healthcare providers in the Wuhan province of China, as well as in northern Italy, have become infected at rates as high as 20%. So their healthcare providers are contracting the disease. there is particular concern around airway management for several reasons. One, we would get much closer to mucous membrane surface contact, which perhaps is the most important consideration. But a lot of attention has come to aerosolization. So it is known that this virus or similar predecessors have the capacity to aerosolize. And so there are recommendations from the CDC and others to maintain airborne precautions for aerosolizing procedures, and airway management is considered one of those aerosolizing procedures. So it becomes important for anesthesia providers to participate in that proper PPE practice during airway management. And we also know that there are a lot of folks out there that are carriers of this disease that might be asymptomatic and shedding virus. So the practice of airway management has and the appropriate PPE precautions for airborne have expanded beyond that COVID positive patient into a broader population of other patients that may be asymptomatic carriers.
Hey, great. So I wonder what steps people can use to avoid aerosolization. For example, rapid sequence induction, deep extubation. Should we use LMA? Should we not use LMA? Should we be using fiber optic intubations? What can we do?
I don't know if I have a perfect answer. I can give you my thoughts. I've seen a host of different recommendations out there. It's probably, I think it makes sense to avoid procedures that add to the aerosolization. So using high flow nasal oxygen, using CPAP BiPAP as a bridge to intubation. So wherever you can more electively intubate and intubate early, I think it's probably a good idea. If one is mask ventilating with the appropriate filter on a circuit, it's probably not a harmful thing. So I don't know that every patient, COVID or not, requires a rapid sequence intubation. I'm a big fan of video laryngoscopy. You can talk me into using video laryngoscopy for every intubation out there. So I think it's also not a bad idea for this risk consideration, because it takes your face that much further away from the airway, and I think that can be protective. Certainly don't know if it is. But by far the most important consideration is our appropriate donning and doffing practices around our personal protective equipment, maintaining good contact precautions, and making sure that when we remove our protective equipment that we do it in a fashion that doesn't contaminate us.
I think that's fair, and it's always tricky. Removing that stuff isn't necessarily intuitive, and it takes practice, and it sometimes takes people watching you to make sure you're doing it right.
It's interesting that the practice of having a independent observer watch your donning and doffing practice may be the most protective thing, because they're much more likely to detect moments of contamination in an individual provider. I've personally peer-reviewed several manuscripts that describe that practice well, and several practices where that was performed well, and there were zero provider infections associated with airway management. So I think there's an association there that might have some meaning, and I think that's an important practice consideration.
So obviously, anesthesia providers want to mitigate their risk of infection. One way to do that that's in the news is through the use of masks. But we're all aware that these have been in short supply for many providers, or at least in the United States. What are the issues between using regular surgical masks or N95 respirators for intubation?
Well, it's about level of protection. A regular surgical mask protects against a lot of contact, keeps you from touching your own mouth and face. And so there's a certain level of protection that we all get from regular surgical masks, and that use may be growing in the community as well as in healthcare settings today. Clearly, an N95 respirator provides more protection against aerosolization, which in theory occurs. And so it's probably an important practice for intubation of a known patient or a suspect. The question is what to do with all of these others. As testing ramps up for this disease, that might be our best opportunity to conserve supply, which is which is quite a problem. So we know who clearly doesn't have it, that we don't need to consume our PPE for that patient population, and we can conserve it for those who are known to be higher risk.
Along with the masks, people are commonly asked to use eye protection like tight-fitting goggles or face shields. Do these really protect against infection?
I don't know. I'm not an infectious disease person, but again, I think there's a barrier there to touching your face and touching your eyes, which is a clear mode of transmission, either from you as a provider to another provider or patient, or from the patient to you. So a barrier there is important, but theoretically, aerosols can come, up from a field of an airway into your eye and transmit infection that way. So tight-fitting face shields could potentially help with the aerosolized exposure to your eye.
I guess it's possible infectious particles could land on your face, and if you touched your face, then it could further contaminate you.
I think that's the thought. But more importantly, again, I think if your hands, for example, even with a glove on, were to touch a surface that's been contaminated by a patient or a patient's mucous membrane, and then you were to touch your face, I think that is a quite probable source of transmission, and whatever can be done to avoid that contact is best for all.
That's great. Hey, let's conclude this discussion by discussing rescue airway techniques. As you know, as anesthesia providers, we sometimes will be called to intubate someone that other providers have had difficulty intubating or feel may be a difficult intubation. They may be patients that you can't ventilate for one reason or another, or you are hesitant to ventilate. In your opinion, what would be the best rescue technique for a difficult intubation patient, a difficult COVID patient?
Well, I would say adhere to standard practices, which include rescue algorithms described by the ASA and others in a setting of difficult mask ventilation, difficult intubation. I would proceed next with an attempt at a supraglottic airway. That's not a secure airway, so to speak, but there might be less aerosolization with that approach than with cutting into the trachea, which might induce coughing and other forms of aerosolization. So, of course, then when that fails, surgical airway is the appropriate next step to try to save the patient. But I would add one kind of caveat to all of this, is that these are airways we can't crash into. We need to don the appropriate PPE to protect ourselves, and it's not that we want to sacrifice care of our patient, but it's not appropriate to approach any airway management in a COVID patient without the right protection.
That's a very good point. Well, I appreciate your time, Dr. Aziz. This has been a very informative discussion, and we look forward to sharing it with our membership.
Hey, thank you, Kevin. It was a pleasure to talk to you.
Next, we'll talk with Dr. Philip Kurian, an assistant professor of anesthesiology at the University of California at San Francisco. His usual portfolio includes sleep medicine, but very recently he has been working on cleaning and repurposing single-use PPE to help institutions with limited supply stretch it a little further. Welcome, Phil.
Thanks for having me. And as you mentioned, this is quite a departure from what I'm normally doing, but in these times, I'm happy to pivot to try and help out and lend some expertise.
Yeah, thank you. It's getting to be kind of creative in terms of how we spend our time. So I keep hearing in the news about all of these shipments of personal protective equipment that are supposed to be arriving at our hospitals any day now. I can't speak for you guys, but at our shop, we've been waiting for weeks and there's really been no sign of anything new. So I assume that we don't want to run out of supplies completely before we start talking about cleaning and reusing items. How low should our supplies get before we start seriously considering or even start repurposing these items?
Well, I would say that the fact that we're actually discussing resource scarcity in this arena means that the supplies are too low. And what we do know is what we actually have in front of us. What's in the supply chain is, as you mentioned, currently variable. And we do need to have backup plans that reflect this uncertainty. Currently, PPE estimates based on inventory and expected reuse guidelines at our institution give us a few weeks supply. And our intention is to be way ahead of that deadline to be able to sterilize, reuse, and extend that supply in the most effective way possible. And in particular, I want to pay additional attention to the N95 respirator, as this is the most challenging aspect of critical PPE to procure and to sterilize.
What's stopping us from just reusing single-use items right now? I mean, if it's not obviously contaminated, it doesn't have like slime or blood or something on it, why can't I just use the same face mask or the N95 respirator all day, or maybe bring it back tomorrow and use it again? What's the issue?
Well, so, when we were looking into this, there's no clear recommendation on how many times a single mask can be worn and reworn. Obviously, if it's damaged or soiled, it should not be reused. The current guidelines at our institution suggest that the mask, again, if it's not soiled, damaged, or exposed to an aerosol generating procedure from a high-risk patient, should be reused for the entire shift and then discarded at the end of the day. The concern is, for multiple days, is that this cumulative exposure that the mask sees, not only to viral pathogens, but other pathogens as well, will really increase the risk for the healthcare provider. And thus it needs to be cleaned and handled appropriately if we're going to reuse it. So there are a few other things that need to be considered for a respirator, actually for its use during the shift as well, how to don and doff and store it in between use. Those may be more institution specific, but the guiding principles for in-shift use would be storage in a clean and dry place with attention to keeping the contaminated surface, which is the outer side of the mask and the elastic bands, away from the clean surface, which is the inner side of the mask. So far, we've seen some creative solutions involving paper bags and Tupperware that have been utilized for this purpose with reasonable practical deployment. But what we don't know yet, as is the case with a lot of information around this particular pandemic, is that we don't really have sufficient data to know with certainty whether those methods are sufficient for reducing risk to the provider.
That makes sense. Cleaner is probably always better. And who knows what kind of contamination these items can get just through regular clinical use. So if we were going to clean PPE, what are the considerations?
Well, Kevin, as we talked about, this really should be a last resort option, but it does require a lot of substantial planning and organization. And the main principles of sterilization and reuse of PPE as it relates specifically to the N95 masks are focused on methods and workflows that are centered around sort of four core principles. The first principle is that you want to choose a method that does not alter the integrity of the N95 mask. So most people may be unaware that there are multiple layers that are embedded inside the mask, some with charged or polarized surfaces, and those layers and that charge needs to be preserved during the sterilization process. And some methods like chemical immersion, for example, can really alter the charged surfaces and therefore affect the integrity. The second guiding principle is that we want to eliminate pathogens. And we're not just talking about SARS-CoV-2, we're talking about other pathogens like C. diff, for example, and the spores that come along with that. Because again, we're accumulating risk by wearing this mask, seeing many patients during the day who have different pathogens, and we want to make sure that we effectively get rid of those during the sterilization process. The third principle is that we want to be able to execute on the sterilization process as near to the point of care as possible, ideally in the hospital, and on campus. And that really is to try and avoid cross-contamination of other facilities. And then the fourth guiding principle is that we're trying to return the mask to the same individual. And this is actually a recommendation from the CDC itself, which requires a lot of logistical planning around that to make it happen.
What sorts of cleaning options are under consideration right now?
Well, thankfully, we're not reinventing the wheel here. A lot of work has been done by other colleagues at institutions around the country who've also been, preparing well in advance for other pandemics like Ebola, for example. So to name a few of these institutions, University of Nebraska, Duke, and UCLA have clear SOPs or standard operating procedures for different decontamination methods. And our team here at UCSF, which is a collaboration of multiple groups within UCSF, different departments, environmental health and safety, engineering, and collaborators from UC Berkeley as well, and others, are working hard to adapt these protocols to other systems that are available to us. And we've really narrowed these processes down to two leading candidates. One is ultraviolet light decontamination, and the other is hydrogen peroxide decontamination, hydrogen peroxide vapor. But there really are four general categories for decontamination that we that may be considered in this process. So to go into a little bit more depth about each of these, I'll just kind of list them off. The hydrogen peroxide decontamination method really requires vaporizing hydrogen peroxide, very specific part per million ratio for a set amount of time, and requires significant engineering and safety controls, but is very effective at controlling pathogens and does not affect the mask integrity for a number of cycles that were tested. It's most likely that the mask will be taken out of circulation because of wear and tear from reuse rather than the sterilization process itself. As I mentioned, the engineering issues around it are significant. So hydrogen peroxide vapor will need a room that can be vented to the outside and with ventilation that can be controlled, because it presents a significant safety risk for the operators who are managing that decontamination process if it's not well ventilated. So it does require significant engineering and safety setups. The second method that we are highly considering is the UV ultraviolet C system, and it does require some calibration and continual reevaluation. Based on the data, wavelength of about 254 nanometers at a dose of 1 joule per centimeter squared is sufficient for pathogenic decontamination and is also safe for the filtration efficacy of the mask. And there are a number of commercial systems that are capable of doing this. We're exploring a few, but there are also lab-based portable UV ovens. So things that have been used in the lab to cross-link nucleotides for northern or southern blotting that can be repurposed for this type of initiative. And then also biosafety cabinets in the labs can be considered as well. However, we've done some testing with UV radiometers to ensure energy exposure and provide times and workflows. And the biosafety cabinets are not only not in the hospital, but they also operate at a lower energy level, if you will. So it makes the workflows a lot more limited. The third option that is being considered as well is dry heat sterilization. And basically, it has been documented that 70 degrees Celsius for 30 minutes, SARS-CoV-2 will not be able to survive. And so we are looking at potentially repurposing some of the ovens that are available to us in the operating room. Those are the ovens that are available to warm blankets and fluid, can actually achieve those temperatures and can be repurposed for this. However, we're a little bit concerned about this method because 70 degrees C for 30 minutes might be effective for SARS-CoV-2, but insufficient for other pathogens. So we're a little bit wary about wide-scale deployment of this, but it could be used in concert with the other decontamination methods that I've discussed as maybe a first line decontamination method before moving on to the other methods. And then the fourth thought, and this comes from Dr. Tsai, who is the inventor of the mask, the N95 mask, is that leaving this mask in a dry area for a number of days provides time without a host, which is necessary for SARS-CoV-2 to survive and propagate. And so if you have foresight and the ability to plan, taking a mask out of circulation for 4 days can be considered. However, again, it is unlikely that it will kill other pathogens. And this hasn't been particularly tested against any of the coronaviruses, whereas some of the other methods have been tested against other coronavirus strains, but none of them have yet to be tested specifically for SARS-CoV-2.
That's interesting. It's kind of a scary world if we're considering just baking our PPE in an OR oven, because it's the best we've got. But
yeah,
I'm very curious about this hydrogen peroxide mist that you've got. Is that something that, if operationalized, and I realize that's a big if, that can be implemented at non-academic hospitals?
Yeah, so that's a great point. So there is precedent for terminal decontamination of rooms, and it really depends on what systems hospitals are using to be able to execute that. It can be done in non-academic settings. However, the engineering controls around that should be very, very clearly paid attention to, because, as I mentioned, it's probably the riskiest of the options that I've mentioned, but possibly the most effective. In that sense, the SOPs that are available from Duke, which has implemented this method of decontamination, outline a lot of the specifics that would be required for making this happen. I also want to point out that not all hydrogen peroxide systems are the same. For example, the system that we are using or we have available to us at UCSF uses silver nitrate as part of the solution. And so we have to specifically test the filtration of efficiency of the mask after exposure to the silver nitrate, because it might affect the mask efficiency. Whereas hydrogen peroxide by itself may not affect or does not affect the filtration of efficiency for a number of cycles. We have to be aware of the solutions that are available and being used, and they need to be tested appropriately.
Well, these are certainly interesting times. I never thought I would be having discussions about possibly reusing one surgical mask on a different day, but these are the realities I'm in. Now personally, I'm one of those doctors who feels comfortable when I have a plan A, plan B, C, D. I have backup plans for things I need to do. I have found, though, that there's plenty of people that would rather not think about plan D while they're still working on plan A, that they'd rather not plan that far down the pipe. Now, I suspect that you, like me, would like to have some contingency plans. That's why you're doing this kind of work. Do you meet much resistance from people who don't believe that we'll ever get to the point where we're cleaning and reusing PPE? And if you do, how do you overcome their resistance?
So that's an interesting question. And, I think the reality of our PPE limitations are in full view currently. This pandemic has really strained resources in other settings and is widely reported and documented clearly, along with the frustrations of healthcare workers. And our goal is to provide options where our staff can be confident that they have a functioning mask that can reduce their risk, when the alternative may be having no PPE to use at all. So in that way, we really haven't encountered much resistance from providers. I think they're generally much more appreciative of these efforts, recognizing the limitations that are currently out there. I think the real challenge is having sufficient foresight from leadership in the middle of a crisis response to make these projects work effectively, especially because, as you mentioned, this is literally a plan D when they might be focused on plan A and B right now. Having the foresight to look at a D and realizing that that's important and being able to dedicate the significant human, physical, and engineering workflow capital that's required to get it done does require a little bit of attention or a lot of attention from leadership to mobilize those resources to make Plan D work.
Great, thank you, Dr. Kurian. This has been a very insightful view on cleaning and reusing PPE or the challenges that we face therein. Certainly, we hope we never get to that point. But thank you very much for your work. This is very interesting, and I think we all look forward to seeing where it goes.
And Kevin, I have a special guest today. I have Dr. Bob Webster. He is the Schroeder Professor of Mechanical Engineering at Vanderbilt. He's an expert in robotics and image-guided surgery and has spent his entire career partnering with physicians to invent new medical devices with over 30 patents awarded or pending. He is also an entrepreneur and serves as president of 2 startup companies in the surgical robotics and endoscopy spaces. Thank you for joining us, Bob.
My pleasure.
So, Bob, I hear you at Vanderbilt, correct, are preparing for influx of patients that might be infected with COVID-19. Can you tell me more about the ventilators you're making?
Yeah, absolutely. We, as many people in the country, got a little bit worried, especially a few weeks ago, when all the projections were showing that the COVID-19 peak might be really, really big. And we're hearing reports about people running out of hospitals, running out of ventilators around the world, and thought, well, what could we do, here in Nashville in case the same thing happened either at Vanderbilt or other hospitals around the area. And so that was really where this all came from. And the ventilators we're trying to make, we wanted to make something ultra simple, something that anybody could make and could make essentially with tools and parts and everything that you would have in your garage. So things you can make out of plywood, we built the whole thing around a windshield wiper motor and came up with the concept of trying to squeeze an ambu bag with a mechanical device so that if everything went south, we wouldn't have people sitting there all day trying to keep patients ventilated on ambu bags by squeezing them by hand. So just wanted a mechanical device that would sort of replace a person in that role and could help, one really expert physician treat a lot of patients rather than having a lot of med students squeezing ambu bags.
That's really neat. So what inspired you to use a windshield wiper motor to squeeze an ambu bag?
Yeah, so we looked around at what other people were doing. There was a bunch of engineers around the country trying to come up with solutions to this. And a lot of them were using devices that we normally use in research labs. So I run a robotics lab, and we use high-end components when we're making surgical robots. We use, expensive motors that have really high accuracy encoders on them, which are not easy to get. They usually come from Switzerland. They're like 8-week lead time. So these are not the kind of thing you want to build a ventilator around when you're doing it in an emergency scenario. So the very first component we were thinking about is what can we use for a motor that everybody would have, that you could get anywhere. And we thought, well, there's cars everywhere and there's windshield wiper motors everywhere. You could go to a junkyard and pull, 100 windshield wipers motors if you needed to, and they're all around the world. And so that became the core of the design. And then we thought, well, how can we put parts around this motor in order to squeeze the ambu bag and make it entirely out of things that we have sitting in our garages?
Were there any major hurdles or setbacks for this process?
Absolutely, as with any process, there's going to be setbacks. Probably the biggest one for us was when we went to do our first animal study, which was about 2 weeks into the project, which, by the way, is lightning speed. Normally projects, when I build a new medical device working with a doctor, it'll take 4 or 5 years before we get to a first animal trial. Here we got to it in 2 weeks. But we went into the first animal trial and wasn't working at all. The animal didn't seem like it was really breathing off of our ventilator. And we just weren't getting good, oxygenation, good, vitals on the animal. And we realized that what it was the dead space in between the ambu bag's outlet and the animal's mouth. So there was a tube that ran from the ambu bag all the way over to the pig, which is probably about 2 feet long. And just the compressibility of air and that dead space there caused the animal to be rebreathing some of the air that it was breathing out. And so we learned from that first animal study that you've got to put the valves, the PEEP valve and the one-way valve that closes when the animal exhales, you've got to put those right next to the mouth. And, in an ambu bag, they normally are right next to the mouth because they're built into the head of the ambu bag that's right on that cup that goes over the mouth. But when you're moving that ambu bag 2 feet away from the animal or the patient, you need those valves to be right at the mouth. And so that was the biggest lesson from our first animal study. We ended up fixing that with one of these single limb circuits that they use for transporting patients. And that worked like a charm. So second animal study went great. Animal breathed on the ventilator for over 4 hours straight. Absolutely no problems at all. So that was probably the biggest hurdle, but also pretty quickly solved.
And that's actually really interesting because I'm a professor of anesthesia, and I'm teaching residents about Mapleson circuits, all the stuff that I memorized right before my test that I subsequently forgot, and how close those valves are to the patient make a lot of difference with rebreathing and stuff like that. And I just wouldn't have thought of that, despite that being something I'm supposed to know as an anesthesiologist.
Absolutely. I got to say, one of our the surgeons we collaborate with, Fabian Maldonado, called it. I mean, that the morning of or the day before, he was like, I think we might have trouble with this dead space. Didn't occur to any of the rest of us, and we're like, yeah, I'm sure it'll be fine. And then he was, when we got into the experiment and we saw that we did, we're like, yep, you're right, Fabian. Way to go.
I just made a Jeopardy response for the residents that were non-clinical because of the COVID virus. And so that's really ironic. So about how long does it take to make one of these ventilators?
So if you had all the wood cut the right way, it'd be about 2 hours to fully assemble a ventilator. That includes like soldering electronics, screwing everything together, and downloading the code into the microprocessor. So I'd say about 2 hours if you had all the pieces. If you were to start from just pieces of plywood that you got from Home Depot, probably about 4 hours because it might take you about 2 to cut all the wood to the right sizes.
Okay, and about how much does all the supplies cost to make one?
Yeah, they're very inexpensive. It's about $200 total for all the parts. So that was one of the goals too, because we really want to see this used in around the world, low resource settings. So yeah, $200.
Yeah, that's actually cheaper than some of the pulse oxes we're using. What kind of future do you see for this kind of device?
Yeah, so hopefully it never has to be used. I mean, that would be the ideal, right? We don't run out of real ventilators, because this would only be used in an emergency setting when you don't have any other ventilators. You've used, all the ones the hospital has, all the ones you normally use for surgery, all the portable ones you got, and then you still have patients. Then this is when you'd use our device. But really, what we are hoping for it is to be able to be used all over the world. And so, in some parts of the country, like we've been talking to folks in Afghanistan and in Kandahar, the main hospital has 5 ventilators total. So there's no doubt they're going to run out. And so what do you want to do? Do you want to retool a factory in the USA and take like 3 or 4 months to spool up and build a bunch and then try to ship them and try to get them to places like Afghanistan? I mean, absolutely not. You'd like a design that, in your local area, you realize that your local doctor's having trouble as an engineer or just a hobbyist or anyone, you realize the hospital's having trouble, people are in trouble. You go to your garage and you get on our webpage, download all the plans, and build one of these yourself. So we'd like it to be that kind of it's an open source thing right now, and we'd like people all over the world to be able to build these as needed on site wherever they need to be in the world.
And so that's the last little bit that I wanted to ask you about. Is there any place right now that listeners can find more information about how to build and make these ventilators?
Yeah, absolutely. We've got a webpage. It's called vandyvents.com. That's where at Vanderbilt, so that's where the Vandy comes from. It's not endorsed by the university in any way. We're, we happen to work at the university, but we're doing this, on our own as private citizens. So vandyvents.com, though, is the website, and it has all the plans for how to cut the wood, how to wire up the electronics, what to buy, all the parts, pressure sensors. So the goal there is that anybody who has a, home wood shop and a little bit of soldering skills would be able to put one of these together.
And hopefully you'll be able to see that link there either in the comments or on the podcast itself for you guys listening. Thanks, Bob. Was there anything else you want to tell us before we move on?
Yeah, just a couple things. That this has been a huge team. It's been great, and the only way it happened is doctors working with engineers every day. So Duke Harrell is my main medical collaborator. He's actually a urologist, but I wouldn't have gotten into this project if he didn't call me and say, hey, we need to work on this. The things are getting bad in other places. And we never would have been able to go from nothing, from napkin sketch, to where we are now without Kevin Galloway, who's another mechanical engineering professor. And it was his napkin sketch. It wasn't mine that became the basis for this. And he did a lot of the woodworking and windshield wiper motor putting together. So big team of people and established relationships between doctors and engineers is really how this whole thing came together. And so then Fabian Maldonado, Matt Bacchetta, their pulmonologists at Vanderbilt, and just every day being able to call those guys and be like, how do you treat patients now? What matters? What's the minimum set of requirements in a ventilator? Without that, there's no way as an engineer. I'd never built a ventilator, didn't know how they worked, didn't know what they were, 3 or 4 weeks ago. So it's been awesome to see this team come together and put something together like this.
Well, thank you, Bob, for sharing with us.
My pleasure.
Well, that was a great couple of discussions. I'd like to thank all our panelists for agreeing to be interviewed by us and collect their insights on this. We wanted to present these particular topics because it's important for us to think creatively about the problems that we're facing and try to figure out safe ways that we can accomplish usual care. And that's tricky because we're short on a lot of things. And the situation I would never want any of us to be in is to watch a patient in front of us die of something that in normal times would have been an imminently treatable and preventable condition. So it's good to think about how to avoid our situations, how to keep ourselves safe, and how to preserve our resources. And who knows? I'd like to think that we could learn from these experiences. We could apply what we've learned to new situations if they should appear that maybe are not even related to what we're going through, or that we can prepare for the next potential problem. It'd be nice to not get caught by surprise the way that we were this time. And I think it's probably I think most of us will be aware of the need to practice and promote emergency preparedness going forward.
I think that's really thoughtful, Kevin. I also like to thank all panelists. Thank you, Doc Matters, for hosting us. If anyone has questions or comments, leave them below. We will try to respond back to them in a short period of time. It's good to be a part of this.